Some of the most serious diagnoses in pediatrics begin with common symptoms. A child comes in looking pale or with a febrile illness. They've been more tired than usual. Maybe they're bruising easily or complaining their legs hurt. Individually, none of these symptoms are unusual. Together, or with persistence, they can tell a different story. Leukemia is the most common childhood cancer, but its earliest signs often resemble the everyday illnesses pediatricians see in their clinics. This is Charting Pediatrics. As we dive into the diagnosis and treatment of leukemia, I am excited to introduce a new voice to the podcast, a voice that will become familiar to our listeners in short order. Dr. Ashley Rogers is a pediatric oncologist at Children's Colorado and is on faculty here at the University of Colorado School of Medicine. Ashley is also the newest host for Charting Pediatrics. This is also my opportunity to pass the microphone as I close out 9 years as hosting the podcast. I couldn't be happier to welcome the incredible Dr. Rogers, whom I have been fortunate enough to know since she was a pediatrics resident and I was a fellow, and she put up with me then and is putting up with me today. Ashley, welcome to our first podcast as a guest, and an even bigger welcome as our newest host.
Thanks so much, Dave. It's really a pleasure.
So let's dive into our topic. So Can you briefly explain what leukemia is and what are the major types that we see in children?
Sure, absolutely. Leukemia is basically a clonal proliferation or an overgrowth of cells from the bone marrow. So these could be lymphoid cells or myeloid cells. And when they grow in abnormal clones, they take over the bone marrow, and they can also take over other tissues where blood cells are produced, such as the lymph nodes or the liver or the spleen.
So it starts in the bone marrow and then can spill out, so to speak, into other places?
Usually it starts in the bone marrow. There are some children who present with this in the lymph nodes, but we think of it as a disease of the hematopoietic or blood-forming cells.
Right. And I know that eventually guides our diagnostic pathway, but we'll get to that in a few minutes. It's obviously still the most common childhood cancer diagnosis, but still relatively rare. But still, we as pediatricians are always afraid to miss it, right? So what are the earliest signs or symptoms that should raise suspicion for our community providers?
This is such a great question, and I think you hit the nail on the head. Although cancer is more common in adults, it still is really rare in children. So that makes this a presentation that is rare for general pediatricians to see. In a solo practice, you might see one child with a new cancer diagnosis in 10 or 20 years. In a bigger practice, probably 1 in 5 years, but that makes that a challenging piece to pick up. I also think the challenging piece is that a lot of the symptoms of leukemia present like normal common childhood illnesses that may be less severe.
Which is the most scary part. Yeah.
It is. And I think there are ways we can break this down so that we hopefully, don't miss these cases. The best way I think to think of symptoms is what is happening in the bone marrow. So when these cells are proliferating uncontrollably, they're taking over the bone marrow, which is the home for all the normal blood-producing cells. And then those normal healthy cells that we need to survive don't have room to grow. And so that's where the majority of the symptoms come from. We can't produce normal red cells, so children have symptoms of anemia, which we'll go into. We can't produce normal platelets, so children have symptoms of bleeding and poor blood clotting. And then they have abnormal white cells, the healthy white cells that fight infection and help with growth and other development can't, produce themselves normally. So children can have recurrent infections. And I think we can break down each of those. But in addition to those symptoms of the blood counts, it can just be really painful. Having a lot of overgrowth of these large cells in the bone marrow is just really painful for children. So a lot of kids come in with bone pain. And then it can take over the tissues that also grow blood cells. So lymph nodes, liver, spleen, and those can become enlarged, such as lymphadenopathy.
So as we think about bone pain in particular, is there any distribution of that would be concerning? Because we see a lot of kids complaining of musculoskeletal complaints throughout childhood for various reasons.
Yes. Yes. And I think, I don't envy general pediatricians. I think this is one of the hardest pieces to pick up. A lot of children do have normal growing pains, or they do have normal athletic pains. When I think about bone pain for leukemia, though, there are a couple of things that can differentiate that. And I think the number one thing is really the severity and the progression. Bone pain from leukemia is pretty awful. It can be quite painful, and it doesn't get better. It progresses over time. So a child who keeps coming back with bone pain and it's starting to limit their daily activities, these are not often children who are playing vigorously during the day, have a little bit of aching legs, and then sleep through the night. This pain progresses where children can actually have changes in their gait. They can have limping. I think limping is a big sign that always needs to, have further evaluation, or pain that wakes children up from sleep at night when they're totally at rest, not doing anything, and they actually wake up with pain. It can be a little different than rheumatologic pains as well. Certainly, I'm not a rheumatologist, but morning stiffness is different than the bone pain of leukemia. That seems to tend to be worse in the evening after a long day.
That's super helpful.
Yeah.
As you think about some of the constitutional symptoms like fever, lack of energy, etc., how do you contextualize that when we know that it's normal for kids at certain ages to get multiple viral illnesses in a year?
Yes.
And how important is that longitudinal relationship that a pediatrician has with a patient that's helpful in this regard?
Yes, I think that is huge. I think general pediatricians who have amazing connections with their families are the first to often pick this up and the most astute at recognizing, hey, this child I know well just doesn't seem right, or the family is more concerned than they usually are. In terms of the fever and recurrent illnesses, a lot of children with leukemia do present that way because they don't have normally functioning white cells, so they can get more common infections. And I start to think about leukemia in a child who is having either persistent fever that doesn't resolve or recurrent febrile illnesses, especially with a lack of recovering in between. Most healthy kids who are having random febrile illnesses, they get better in between and they go back to school and they're active. These children seem to just get bogged down and not quite ever recover. So I think that's part of it. And then taking the fever and the illness in conglomeration with potentially other symptoms that you would pick up at the same time is really a nice clue. So we talked about anemia. I think that's a very common presenting symptom for leukemia. Pallor is one example, and I think that general pediatricians are the most astute at picking that up. Sometimes even families don't recognize how pale their children have gotten because if you see someone every day, pallor progresses slowly.
It's a slow wind down.
Exactly. Yeah. So changing color each day, maybe you don't quite notice until it gets really severe. But a family friend or a pediatrician who hasn't seen the child every day can say, oh gosh, this looks different for me.
What are the things that we should be looking for in exam in addition to looking for pallor?
Yes. I think pallor and the other symptoms that go along with anemia, so children who might be more lightheaded, might have had an episode that seems like syncope, tachycardia, just fatigue, not the same level of get up and go. And then in terms of low platelets, that's another big presenting sign. So children can't form platelets normally when their marrow is overcome with leukemia. So they can present with bruising, petechial rashes. Now in pediatrics, we see a ton of children with bruising in their lower extremities. They're active, they're go-getters, and toddlers. But bruising in unusual places, like on the abdomen or the face, or increasing bruising that doesn't seem to be explained would be one. Prolonged bleeding in a nosebleed you just can't stop, or petechial little purple rashes. That's very unusual. If you don't have an area of trauma, like a young woman shaving, that may be explained, but having tiny purple dots for no reason. So that would be a good exam finding. And then lymphadenopathy is common in leukemia, and also overgrowth of the liver and spleen. So checking carefully for hepatosplenomegaly. And these can be lymph nodes everywhere. So neck, armpits, groin, a full lymphoid exam is helpful.
So as I think about a patient that I'm concerned about, the first test I would order would be a blood count, a CBC.
Absolutely.
And what are the things I'm looking for, and how sensitive is a CBC in the setting of leukemia? Could it potentially come back and be falsely reassuring?
I think you're right. It can be falsely reassuring, but most children who present with leukemia do have some abnormality on their CBC. It may not be dramatic, but things that we would be very concerned for leukemia would be out of the 3 main cell lines, so looking at red cells, white cells, and platelets, having 2 out of 3 down would be a red flag. Like if you have a child who isn't quite feeling right and then has both anemia and thrombocytopenia, I think that needs further evaluation. a child with single prolonged anemia that doesn't fit your classic iron deficiency. They aren't small cells. Maybe they're normocytic and the anemia is kind of severe. I think that's a red flag. The white cell count can really do a number of things. You can have children present with leukemia who have low white cell counts or high, a very high count, especially enough to produce some peripheral cells that you look at under the microscope that look abnormal, like blasts or just don't look normal. That's very helpful. That's a very clear sign you might have leukemia happening. But those are the things that I think of when I look at the CBC initially.
And if I were to pick up one of these abnormalities or a couple cell line abnormalities and I call you up, Dr. Rogers, and I say, okay, what's next? And this family gets referred in to you. What are the next diagnostic steps before, a final diagnosis is made?
Yes, we would probably do a little bit of an expanded blood panel.
Okay.
So, and that may be done already in the pediatrician's office. We would look for tests of cell turnover. So LDH is really helpful when cancer cells are turning over quickly. Sometimes, not always, but sometimes the LDH is elevated and that's a good signal. We might add a uric acid, which is another test of cell turnover. Again, not always elevated, but sometimes. And when it is, that's helpful that maybe there's proliferation going on that's out of the ordinary. Electrolytes and liver functions can be helpful. Sometimes those are stone cold normal, but to look for some other abnormalities in that is helpful. So we would start with that general screen as well. And then have pathologists and oncologists look at the peripheral smear, see if anything is signaling abnormality. And if there's concern there, certainly if there are peripheral blasts seen, of course, but even if there's concern that there are too many cell lines down or too many abnormalities when we look at that, the next test would be to look at a bone marrow directly.
That's super helpful just in terms of coaching families on what to expect if they come in to see you. And at that point, you're already having some really challenging conversations with the family.
Yes.
But the good news is that the treatment for leukemia is really, really effective that we have. And so perhaps, Ash, you could give us an overview of what standard leukemia treatment looks like for a child. And then we can talk a little bit about where we're seeing advances in the field, but what's a standard regimen look like and how successful is that?
Absolutely. So we should probably break into two. You had asked me before, and I'm sorry I didn't answer before, but two main types of leukemia we see in children. The most common is acute lymphoblastic leukemia, ALL. And that treatment we have improved dramatically over the last, 100 years. I would say in the prior decade, children usually died of leukemia because of lack of supportive care, lack of transfusions, and lack of knowledge of what chemotherapy regimens were the best. And nowadays, the great majority of children live long and lovely lives. So the general treatment for ALL, so acute lymphoblastic leukemia, is intensive chemotherapy, combinations of medications that they get through a special IV line, and then in some cases, immunotherapies. And when I think about leukemia, I like to think about it like a boxer. So we use combinations of medicine because any one leukemia medication alone isn't as effective as combinations. It would be like a boxer who might have an amazing uppercut and maybe the opponent would evade that initially. But eventually the boxer knows they need to have multiple shots. And that's the same thing as chemo. So each chemotherapy phase has multiple medications, somewhere between 3 and 5 that these children take through a combination of through IVs or orally. And the first 6 months of treatment is more intense. So I would say those children are being seen in clinic once or twice a week for the first 6 months, approximately, depending on, the age and the risk factors. And then they move into maintenance. And the great majority of leukemia treatment, about 1.5 to 2 years, is maintenance, where children are really only coming into clinic once a month, doing most of their medication at home orally, having a full, head of regrowth of hair, getting back into normal life. So I'd say the first 6 to 8 months, we prepare families that's the hardest.
So the whole treatment cycle around 2 years, and the first 6 months really intensive.
Yeah, that's right.
And they have a Metaport placed for the first 6 months, or is that extend for 2 years?
That's a great question.
Yeah.
So all these children have a central line, like you said, either a Metaport or a Broviac, so something that's under the skin or sometimes something that hangs out depending on the type of leukemia. But for ALL, always a Metaport that's hidden, so their friends and family members don't even see it. Mm-hmm. But it allows us to use access in a less painful way. We can, put a needle into the Metaport without causing a lot of pain. And then those medications can go right into the big blood vessels instead of into the tiny peripheral veins where they can cause damage. So children children mainly keep their Metaport for the whole entire treatment.
Oh, is that right?
And that one Metaport line lasts the entire, 2.5 years.
And that's a big step, obviously, when they get that out at the time that
really
they're declared,
yes,
I guess, cancer-free at
really
that point.
Joyous, yeah.
Talk to me about AML
yes.
a little bit, because that is less common, but potentially more significant, more serious of a diagnosis.
That's exactly right, Dave. AML accounts for maybe 15%, depending, these numbers change each year, but far less common than ALL. And its presentation can be a bit different. Some of the symptoms are similar, but AML, those cells are myeloblasts and they're bigger. So they can cause some symptoms of sludging in the blood. Those kids can actually come in looking a bit sicker, having more respiratory distress, having more difficulty breathing, and sometimes more neurologic symptoms from sludging of the brain through those smaller blood vessels. That may not be true at the very onset of AML, but as it progresses, it can have a slightly different symptom profile. And the treatment for AML is also very different. It is harder to treat. It's a more intensive type of treatment. These children get, again, a combination of chemotherapy, but that chemotherapy is so intense that it requires them to be in the hospital during their treatment. So children with AML can have somewhere between 2 and 5 cycles inpatient. So they come into the hospital and get approximately a week of chemotherapy and then have to stay because this chemotherapy is so intense that it really renders them so immune suppressed that we need to watch them carefully, to give blood products, to make sure we don't miss any signs of infection until their bone marrow recovers. And then they go home a bit and come back. And the reason I say 2 to 5 cycles is that it is potentially more likely to need a bone marrow transplant in AML. Children who have good risk factors and have nice responses have 4 to 5 cycles of chemotherapy, and that's all. They may be done in 6 months' time. But children with higher risk factors or initially poor responses to treatment may need to go to a bone marrow transplant after the first 2 or 3 cycles. And that's a different story. Yeah.
Yeah, way more intensive in terms of an experience. One of the things that's been so impressive to me over the decades has been the iterative improvement in terms of ALL treatment for kids, just, gaining a couple percentage points in terms of survival, disease-free survival, every decade in that march towards really eliminating the cancer altogether. And my understanding now is that we're close to 95% for ALL. Is that right? In terms of survival? For certain types.
Yes, exactly.
So let's talk about that because I think it's important. So when a diagnosis is made, we have different tools to define the subtype of ALL. So talk to us a little bit about what advances have been made to understand the risk profile of the types of ALL.
Yes, you're right. I think it's been really dramatic. And every year it changes. Just even in the time I've been working, I think our treatment and our delineation of the cells have changed. So the first thing we do is look at the cells under the microscope morphologically. What do they look like? What kind of cells are they? Do they look like lymphoblasts? Do they look like myeloblasts? And then we have specialized testing to actually define the immunophenotype on the cells. So those are the markers on the actual immune cells so we can know for certain what types of cells these are. So running this through a flow cytometer, the pathologist can tell us what markers are on these cells. So we know, is this a B cell ALL? Is it a T cell ALL? Or does this look more myeloid like an AML? And then beyond that, something that's really advanced over the last, 10, 20 years is to break down the genetics of those leukemia cells and look at cytogenetics and molecular testing that tells us what genes are present in those cells. And some genetic alterations or changes in leukemia cells are actually favorable and make this type of leukemia more treatable. So those are children who might be very low risk and can benefit from less intensive therapy. And as you say, have, survival rates of 95 percentile. Then there are genetic markers that make leukemia cells more difficult to treat. And those children require more intensive therapy. And then the last piece of that puzzle in making risk is how does a child respond to the therapy we choose based on that? And that is a big, big prognostic factor as well. So the
genomics of the cancer cells will influence decisions made at the beginning of treatment about how intensive you go, et cetera?
That's right. That's right.
Yeah.
And on the first day of starting treatment, we may not have all of that information. So our first choice is what type of leukemia is this? And then what are some basic risk factors? So the age of children makes a difference, their initial white blood cell count. So in terms of age, children who are under 1 and children who are over 10 are higher risk. And both of those populations require more intensive therapy just based on age. So we would start based on the age and the white count, picking what type of treatment these children would require. And then when we get further genetic information, that can influence it later. Do they need to have more intensified therapy later? Do they need to have additional medications added?
Does the higher white count predict potential risk of complications with early treatment?
That's a great question. When white counts are really high in the beginning, yes, we're extra careful. But even low white cell counts can carry some of those same risks. I think you might be talking about tumor lysis. When those cells break down, when we kill them with chemotherapy, they release a lot of products into the blood that we need to be careful about flushing out through the kidneys and making sure that they don't cause damage. So higher white counts carry a higher risk of that. You're exactly right. And so we're extra careful with that, making sure we're using high fluids and certain medications to protect, children's healthy organs.
Ashley, you mentioned immunotherapy as
Yes.
a newer type of treatment. How does that fit into your algorithm and your armamentarium, if you will, of treatments for this type of cancer?
Yes, absolutely. One of the newest treatments that is becoming more routine that many, many children are getting is a new medication called blinatumomab. And that is a molecule that actually helps connect the CD19 marker on a B cell to the CD3 marker on T cells that are killer cells. It actually can connect them physically so that it makes the cancer cells easier to kill. And there were studies in the beginning, this was initially used for children at time of relapse, but now we're using it for more children up front. So children who are standard risk or have higher risk features are getting blinatumomab right from the get-go. And that's been a hugely transformative therapy in the recent past.
That's wonderful.
And then the other piece I think people have heard about a lot is called CAR T cells. Those are more reserved. So that's an actual engineering of a patient's own T cells to be reinfused and hunt down those leukemia cells. That's more reserved for children with refractory or relapse disease. But that's, I think, another upcoming and very promising therapy that's being used now.
Thanks, Ashley. So, these patients, if they're diagnosed with ALL, they go into this intensive 6 months of therapy, this very close relationship with the oncology team that's caring for them. And all of that is, incredibly protocolized and stressful and demanding for the families for sure. What is the role at that point, would you say, for the primary care team? And because so much of it is happening at the Cancer Treatment Center, what do you expect the primary care provider be doing during this intensive phase and even the next 18 months after that?
Yeah, absolutely. I think when a pediatrician and a patient and their family have a wonderful relationship, which so many of them do, I think it's incredibly helpful for families. I think they thrive through this experience better to have someone else to bounce questions and ideas off of. You're right. In the very beginning, most children are coming into oncology clinic twice a week. So the time to have another additional visit is slim. And most questions are answered in that time in terms of acute needs and infections. But I think as time goes on, especially in maintenance, children are not in oncology clinic as much. And I think their questions can really wonderfully be answered in their pediatric office. That's a great time to reinvest in that relationship. And a lot of acute illnesses can be seen in the pediatric office and managed there. I also think pediatricians are so astute at children's growth and development and learning. And that's something I don't think that we as oncologists are as well versed in. And so keeping that, the general pediatric care of, is this child growing and developing and learning and having success in school, that is a very important role also, I think, for pediatricians to keep abreast of. And that we appreciate. I love to have close relationships with pediatricians when I'm taking care of their kids for cancer.
Fantastic. That's super important. Getting back to the diagnosis part, I just because I know that all of us have angst around getting the right diagnosis the first time, but it's not always possible to be perfect, as you know. So obviously we want to make a diagnosis of leukemia before a child gets incredibly sick, but a prompt diagnosis versus a diagnosis 2 weeks later, is there really any difference in terms of treatment response or any of those things, likelihood of survival, if you diagnose it on, July 4th versus July 18th?
I think that's a great question. And I'm not sure we know the answer perfectly. I think in general, we think the sooner the better. But there have been studies that actually looked at that. Does it make a difference if it's a couple of weeks? Does it make a difference, if we do a lot of pre-screen and in other cancer diagnoses? Like they did a study in neuroblastoma. What if we screened every baby? And actually finding that early didn't help because maybe you're finding things that were not going to be as aggressive to begin with. I think that's true with leukemia. Some leukemias are bound to be more aggressive and come on more quickly than others. And that's based sometimes on these genetic changes that we see. So I would like to encourage the population and, general pediatricians who have this really hard job that if it doesn't present itself perfectly in that first time, that's okay. Just the most important thing we can do is keep watching children. If things don't resolve and patients still have concern, we just see them back and keep checking. So I think you're right that catching it on the first try is not always vital. And just maintaining that relationship and double checking when things aren't resolving the way we expect, that answer is going to present itself.
Well, that's reassuring to me. So thank you for pointing that out. Ashley, you've taught us a lot about leukemia today, but I'm also really interested in knowing about why you wanted to be a host of the podcast and what got you interested in this space. I mean, I thought I scared you enough when I was a fellow and you were a resident that you didn't want to have anything to do with me anymore, but here we are together again. So tell me a little bit about what got you interested in doing this.
Yes. Well, I have to say that a big part of that is your mentorship. Honestly, I think, I remember being a resident when you were a young attending and thinking, this is exactly how a pediatrician and a doctor should be. Warm and kind and welcoming. You had amazing relationships with your patients and your colleagues. And I love that. And I felt that same presence in Charting Pediatrics.
Well, flattery will get you everywhere, Anna, so that's very kind of you. Thank you.
But I think that's true. And that's why I want to be part of this Charting Pediatrics, family. I think the conversations we have with specialists and pediatricians are really moving medicine forward, and they're engaging. And I love to hear them, and I love to learn from experts. And I think that's a really special place to be.
That's so fun. It has been curiosity that has been, I think, the most rewarding piece for me over these 9 years is just sitting in this chair and learning from experts like yourself that are super helpful for all of our providers out there in the front lines, all these tips and tricks, and staying fresh on topics that they may not have learned in intensive nature since they were even residents, right? So revisiting some of those topics, learning about what's new and exciting in our field is really what it's all about, and sharing that with others. So this podcast is going to be in great hands with you, Ashley, and I'm very excited that you're joining the team.
Thank you so much, Dave. I know I have big shoes to fill. I'll do my best.
Well, I'm signing off to all of the listeners out there at Charting Pediatrics. Thank you for putting up with me over the last 9 years. Thank you for learning together with me. We made it through the pandemic, and here we are in an exciting new era, hopefully, of really close relationships between us at kids' hospitals and you out in the community. So it's been a really fun experience and a fun ride, and I wish you the very best.